Okay? So that's the key part of this. So once you have these attributes down, and let me just say this, if you don't have these attributes down, just know it's normal to be completely frustrated with developing a treatment plan. And that's just the way it is. And make peace with it, and then learn it, and then it gets so easy. Okay, so once you have these attributes down, then you need to understand the functional neurology clinical decision-making tree, right? So then you have to go through this. You should all be able to diagnose the pattern with the chief complaint. So let me give you, here's a scenario. I come into your office, and I have, my arm is stiff, it's not moving. I come to the side, there's a little tremor on this side. Where in the brain do I have my dysfunction? It's stiff, there's a little resting tremor, arms to the side. Right away, just from that alone, your initial survey, you know I have a left, right? Basic ganglia, direct pathway involvement. So then the next, so like that's it. Like, wow, that was so hard. Right? Another person comes in, and they come in and say, oh my God, this carpet's making me so dizzy. Oh, if I can just sit down and just stare at a blank wall, I'm okay. Where's the dysfunction? It's the vestibular system, right? Cerebellum vestibular system. And if everything is really wired, more than likely it's like a Purkinje inhibition failure issue where they can't dampen their cerebellum, right? Someone else comes in and goes, man, I just couldn't find this place. I looked forever and ever and ever. I'm really having a hard time with directions. I finally got my phone to work. I was able to plug into my navigation system, and I found it. And it's interesting. It's only 2 blocks away. I'd like that circles all over the place. What area of the brain? Medial temporal lobe, right side, hippocampus. Now, when another person comes in, they go, man, I just have such fatigue. Especially I have to focus. I'm in meetings, and I have to concentrate and focus all the time. And it just wears me out. Where is the dysfunction? Frontal. Does that make sense? So the ability to immediately, within the first encounter, right away before you even do your exam, to find the chief complaint is a critical skill. And then if you do the history, you should be able to nail it. And then if you have the brain region localization form on top of the history, you definitely should be able to figure it out, okay? And then you look at then you do your initial survey. You look at their speech, you look at their handwriting, you look at their facial tone, you look at their head position, you just see how they walk. And when you're done with all this, you should have a very good idea how to localize the region. And listen, at this point, we haven't picked up a pin light, we haven't picked up a reflex hammer, we haven't done anything, right? So you should be able to do it. And this is like when people first start learning functional neurology, like, I just don't know where it is. I don't know where to triangulate. You're like, dude, you don't need to do anything but just like observe and know a few concepts, and you can triangulate like that. Okay? So then once you triangulate, then you have to go into like how do you treat it? So then you got to go, okay, let's say it's the left frontal cortex or the right cerebellum or the right basal ganglia. You got to know if you're going to activate it directly itself. That's one option, right? You're going to activate the region you found directly itself, or you're going to activate presynaptic pulls into it. So meaning if I have a right cortical issue, do I activate the left cerebellum, or do I do right cortex exercises? Or do I do both? Right? So that's the next decision. Do you activate it directly, or do you activate presynaptically? So when you look at the flow chart, that's what's bringing up. Identify exercises to activate the involved region, or identify presynaptic projections to the area. And the third thing you can ask yourself is, well, maybe I can just activate regions that share common vasculature, like the MCA. So you want to hit the frontal, but the frontal is just too compromised, so you hit the parietal to get shunt blood flow through the MCA into that region. Okay, so that's why you need to know your vasculature, not just for strokes, but just for the basic concept. And you guys, the vasculature's not that hard, right? You got medial, cerebral, anterior, posterior, cerebral, and then you got your circle of Willis. So not that difficult. So once you develop once you figure out what you're going to do, you get some ideas, you have to basically then go into your exam and play around with it and see what things change, certain variables and certain factors, and see if you get an outcome. And then once you do that, you can develop your brain exercises, and then you have to identify their endurance. So if you found like saccades to the left change their, clonus, then you got to figure out how many they do before they fatigue. When do their eyes break down? When do they start tearing? And then you want to kind of keep it below that number of repetitions so they don't get completely exhausted. And that's the protocol. It's a working process. That's why you just have to have the attributes and know the concepts to then develop further. Now, the other part of this is the neurochemical side of it. So you should be able to look at the key things first. Do they have oxygen? Do they have glucose? Do they have stimulation? Is their brain inflamed? Do they have autoimmunity? And that's its own specialty. Like, we can't cover the depth of all that in a functional neurology program. I mean, the stronger you are with just basic, medicine, like look at heart rates, looking at lungs, looking at the basics, looking at basic blood tests, looking at a urinalysis, understanding nutrition, understanding functional medicine, understanding diet, lifestyle. The better you're at that, the easier this neurochemical part of it gets, right? But as far as brain concerned, you're really concerned about things like anemia, oxygen deprivation, things that cause hypoxia to the brain, dysglycemia, inflammatory cascades, autoimmunity. Those are its own things. So then you look at those factors and you decide what to do. Now, if you do an exam, we have another flow chart where we do repeat testing to see if an individual falls apart. This is the other part of this. I'm kind of skipping around here. But once you do your exam, you might want to dig a little bit. Let's go this way. If you do an exam, if you have an abnormal finding, so you find an area that's abnormal, the left cerebellum, or right parietal lobe or something, okay? So then you ask yourself, well, what happens if I repeat test? So this is the flow chart doing repeat testing. So for example, if they do finger to nose and it's really off, what happens if they continue to do it, right? Or if you do Romberg's and they keep swaying and you give them another chance, they go, close your eyes, and they go, oh. Then you close your eyes. They go, ugh. Close your eyes. If they're getting worse, that's different than close your eyes the second time. They're like, poof, they adapted. Okay? Or close your eyes. Oh, I feel nauseous when I close my eyes. Or close your eyes. Oh my God, I feel pressure in my head. I hate that. Don't let me do that again. That's all different. Okay? So once you find your finding, you want to see where they are. If the examination findings improve with repeat testing, and there's probably not the primary area you need to rehab. So if Romberg's is off and then you do it again and it's totally normal, that's probably not an area you need to worry about. Because sometimes people just have one abnormal test, but as soon as you repeat it, it's gone. Like, here's an example. Someone does this. Whoops. And then the second time, boom. Third time, boom. Fourth time, boom. They're like, yeah, that's not so hard. Now, if the exam findings do not normalize, if the exam findings improve but do not normalize, then you can still rehab them. So meaning this, you have me do I do finger to nose, I do it once, I kind of miss, I then kind of do it again, I kind of get it, and then I get it, and then I get it, and then I miss, and then I miss. I'm not really getting worse, but there's definitely something wrong. So you can then definitely know that you have to rehab them with targeting and so forth as part of it. Now, if your examination findings get worse with repeat testing, then there's significant unstable endurance issues. So if they do Romberg's and they keep getting worse and worse and worse, they're unstable. So if you give them, let's say, balance exercises, they could end up calling you and saying, I've never been worse. This is totally failing. I hate you. You're the worst practitioner ever. I got to warn people about you. You suck. And I've had plenty of those calls, just so you know. It's always so fun. Well, let me explain. You fatigue. The key thing to say is, well, that's very diagnostic. That tells us a lot. And it actually does, but you gotta work your way out. Now, and actually, honestly, the more experience you get, the less that happens. The less often you have to deal with that, because then you're very conscious of those. If new symptoms develop with testing, that's when you're really worried. So if they close their eyes and now they get dizzy or nauseous, or now they get pressure in their head, or you do optic kinetics one time and they're okay, but now they feel pressure in their head, or you do optic kinetics and now they feel like they're moving, they're really, really unstable. Okay? The ones that are really, really unstable are the ones you have to be very careful with doing therapy for. And the ones that are really, really unstable, if you try things with them, you may not change your exam findings. Let me give you an example. Let's say I have clonus on my right side. Okay? You stretch my foot and you get like boom, 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 several beats of clonus. Okay? And then you check my T-charge and they're hyperreflex on one side. Okay? And you check my saccades and to the left, they're really slow. Okay? If I do repeated ones, just my latency gets worse, my speed's off, it's just not healthy. So then you go, okay, we're going to try some things. So you try some therapy and you do it again. And so you go, okay, well, I'm gonna the right cortex, maybe, the left cortex, the left motor strip may be involved with all these right-sided symptoms. So you're going to do some right cerebellar therapy. You do some right cerebellar therapy, nothing changes. Then you try to do his left frontal exercises, nothing changes. Then you try to do support to the same vasculature, Like maybe you just have them feel their arm and feel their leg and feel their sense to get the parietal lobe going. You try that, nothing changes. That's a person who's not going to respond. They're probably so inflamed, have so much metabolic compromise, you're not going to be able to get there with your case. Right now, you got to change the environment so the neurons can branch and they can grow. Okay? What happens is sometimes people get those complicated cases and they're new, and they go, I just can't figure an exercise. I'm not good at this. I can't figure it out. Well, sometimes patients don't respond. You need to know that to any kind of stimulation you do, and that's honestly diagnostic. You got to go there and check various things. Okay, so when we look at those concepts, let me get my thing back here. Whoops. Okay. So we look at those concepts that become very useful to us. Now, just remember the key things we talked about with pathways. Make sure you guys know these key concept pathways. Cerebellum impacts the cerebellum, projects to the contralateral cerebral cortex. Cerebral cortex projects back to the cerebellum, right? The vestibular system projects into the ipsilateral cerebellum. The cerebellum projects to the vestibular nuclei bilaterally. The vestibular nuclei form into the medial longitudinal fasciculus. They go up the brainstem. Then MLF works for the oculomotor system. Cerebellum output to the vestibular nuclei bilaterally. Cerebellum projects out of the vestibular nuclei bilaterally. The vestibular nuclei form the vestibular spinal tract, and the vestibular spinal tract controls the intrinsic muscles. Muscle spindles and Golgi tends to activate the ipsilateral cerebellum. Quick or slow stretch muscle spindles on the right of an extremity activate the ipsilateral side. Mechanoreceptors activate the contralateral parietal cortex. The cerebellum projects into the autonomic centers and causes dysautonomia. The cerebellum projects to the pontine vagal autonomic centers bilaterally. Cerebellum projects into the medial cuneiform nuclei. The cerebral Purkinje cells inhibit output. Ipsilateral cerebellum activates the hypothalamus cortex, activates the autonomic centers on the ipsilateral side, and the basic ganglia is activated by the ipsilateral cortex, by the contralateral cerebellum. All sensory input to the brain is contralateral except smell, and the cerebral cortex activates the periaqueduct area to inhibit pain. Those are the key pathways. So I went through them really quick because I know it's review for all of you, but those few slides, make sure you own that. Because that's how you start to figure out how do I go presynaptically into the area. Okay? So again, if I come with that right tremor and I have the basal ganglia involvement with my right hand, and you triangulate to the left basal ganglia, so what activates the left basal ganglia? The frontal cortex does. So you can do frontal cortex exercises, you can do isocods, you can do cognitive aspects and see if they change. You can stimulate the right cerebellum because they all fire in presynaptically to the basal ganglia, right? And if you see a cerebellar issue, maybe you have a left cerebellar issue, maybe you do presynaptically muscle spinal Golgi tendon on the same side, maybe you activate the cortex by doing saccades, maybe you do optic kinetics, whatever, but then you want to see exam findings change. So those are the key patterns, those are the key concepts as we go through it. So let me show you let's go through some exercises. Okay, we're going to develop a treatment. We're going to do. I'm going to show you some video cases. We're going to localize the area, and then we're going to figure out what are some treatment options as a learning exercise. August 27th, Matthias Ringstrom. Go ahead and move your hands back and forth as fast as you can. Fast. Keep going. Oh. Okay, and bring your elbows in. Do the same thing. Elbows in like this.
Oh,
what do you guys see? And as fast as you can.
How's the left side?
Fast as you can. Okay.
That's okay.
And then go ahead and put palm, slap palm. Fast as you can. That's okay. Hands out. And then go ahead and play the piano as fast as you can. Fast.
You see happening with his left hand here.
Okay.
Cramps.
That's good. And just relax. And then what we're going to do is we're going to have you...
Okay, let's just stop right there for a second. Let me plug this volume in. So what do you guys see? He had left what? Dysdiadokinesia. Right, that was definitely obvious. He had dysrhythmia when he was clapping. It was not the same. He didn't have the volume, but it's imbalanced. And then he did rapid finger to thumb. What happened? He cramped. Okay? So first of all, right off the bat, is it cortical, basal ganglia, cerebellar, brainstem, spinal cord, peripheral nerve? What do you guys think? Cerebellum. So it's cerebellum, and which side? Left. So the first 2 seconds, you're like, okay, something's not good with the cerebellum.
Now, what happens as he keeps doing repeated testing? Does he get better? Does he adapt? Does he like go do? Oh, do, yeah, perfect. No. He gets worse. The movements get more gross, then he starts to cramp. So how's his endurance? Not so good. So now you're going, this person's left cerebellum's off, but his endurance isn't so good, because when you repeat testing, he's getting worse. So right off the bat, you're going to be very careful with that, or you're going to do some, you can look at his whole metabolic cascade of factors that are involved. Okay? Now, in this case, I don't know if you guys remember, but we talked about it in one of the past modules, the whole case, and how we managed them and so forth. Okay, now, stand back a little bit for it. Close. Okay. Go ahead and close your eyes. And do you see sway? So we know his lat. Now, let me stop for a second. What do we know so far? What part of the cerebellum is involved prior to the testing right now? His lateral cerebellum. So now we're going, okay, we know the cerebrocerebellum is off because complex arm movement is the pathway from the cerebellum to the cortex and back. So now we want to check the midline cerebellum. Right? So these are midline cerebellar tests. Go ahead and put one foot in front of the other. And then open your eyes first. Go ahead and put one foot in front of the other. And stay in that position with your eyes open. And then eyes closed. So he's unstable. So now you know his midline cerebellum is off. It's pretty significant. And whenever you see and then instability, the other way with your eyes open first. So whenever you see instability, you always have to make sure you don't have any posterior column issues, check vibration sense, make sure it's not coming from lack of proprioception from his feet to his brain, okay? So he doesn't. So now you have a person who's got, let's say, cerebellar issue. So right off the bat, his cerebellum is off. Do you think it could be midline left or right or just one side? I know the tendency is to stick to left for everything, and that may be true. But at this point, like, you're going to probably want to do stability, general gross stability, because he's going all over the place. Does that make sense? And even though we like to see things cut in half, there's not much. If you have something happening in your left cerebellum that's significant, it's probably happened to the right cerebellum too. The problem is we have a lot of functional neurology coming from a localization, just one area, just one region, part of it. That's not real reality, right? So you could have bilateral midline instability issues because right in the midline he has more inflammation or more injury. Definitely have more left involved hand issues and so forth. So you might do like left-sided coordination activities or therapies with him and maybe do a balance board with him or stability exercises. It's really up to you. Now, what if you put him on a balance board and he focused on his hand, or he really did some focused, concentrated fixation as he's standing on his leg, and then you have him walk with Romberg's again, and it's better? Then that's your therapy. What if there's no change? Let's try a few other things. And you keep going through and try some things. What if everything you do has no impact? And now, as he does it, everything's worse. And you have him do this again, he starts cramping right away. Then you know he's got severe metabolic factors. So just lay off the therapy for a while and then figure out what's going on with his brain metabolically. Okay, so here's another scenario. Okay.
My sugar was way high for such a long period of time. That was on Monday afternoon. I just started.
His right arm is moving
gradually
on its own,
losing control of my right side of my body. Mm-hmm. And then Tuesday, of course, it was worse. Mm-hmm. I mean, Tuesday, Wednesday, and today are all about the same.
So what does he have? His hemiballistic movement on his right side. So what area of the brain's involved? Left basic ganglia, left subthalamic nuclei. So now you go, his left subthalamic nuclei basic ganglia is involved. How do you activate the subthalamic nuclei? I don't know. I don't know. But what fires into it? The right cerebellum. Maybe you put him down and you do some warm calorics into his ear and see if his arm movements slow down. And if they do, maybe do caloric therapy. Maybe you have him just start visualizing he's spinning to the right. And maybe that stops the arms. Maybe it doesn't. Maybe you have to do frontal. So that's the game. You go through and you play with it. And you see what changes. It's going to be different case to case. That's why you have to learn the concepts and not just memorize a bunch of things. Okay? Now, let's take a look at this one. So what are you guys seeing? His head's not stable, right? her, you're seeing titubation of the head. So what area of the brain's involved? Midline cerebellum. This is midline cerebellar pathology, right? Okay, like an essential tremor type of thing. Midline tremor. So now you immediately go, okay, is it left or right? Because these are bilateral, and they usually have a genetic component. So what could you do? You could do the rest of the neurological exam, and maybe see a bunch of parietal stuff, or maybe see a lot of frontal stuff, maybe see some vestibular stuff. Try it, see if it changes it. Because sometimes just integrating the brain makes all the difference in the world. And you're just trying to you have a clinical finding, and you want to see if you can change it. And then you see if you can. And if you can, great. If you can't, you may have a metabolic issue, or you try some things there and you haven't come back, and you kind of work through it. Sometimes you don't know what the prognosis is after the first visit and have to respond to care. You try a few things, you see if they change, if they respond to therapy, or they don't respond to therapy. Okay? Now, here's another scenario. What do you guys see? Okay, watch again. See with his toe on the left side? It's an extensor toe sign on the left. Okay, really subtle. It's there. I mean, it's not subtle. It's pretty obvious, but it's right there. So, what area of the brain's involved? The right motor areas, right motor strip. So, maybe you have the person like contract their left arm and see if that changes. And if that's the case, maybe do a contraction exercise. Maybe you do saccades. Maybe do optokinetic. Maybe do vestibular cerebellum to fire into that area, and then you see if you can change it. Okay, take a look at this one. What are you guys saying? An action tremor or a rest tremor? Rest tremor of the feet on a Parkinsonian pattern. It's got Parkinsonian pattern, basal ganglia. Which side? Left side. What's presynaptic to the left basal ganglia? A left frontal and right cerebellum. So when I say right cerebellum, you can also know, well, what's still after the cerebellum? Right vestibular. So you can do any kind of vestibular therapies, you can do any kind of frontal. Now, if you do an entire exam, you'll find some areas that are not working well, they're down. Maybe his horizontal VORs are off, so you do some horizontal exercises, on the right side to activate that left basal ganglia, because that's what you found, that the vestibular horizontal canal was down as a way to activate it. So the more thorough you are with the exam, the more deficits you find. Once you're trying to hit the area, you try to activate the areas that are inefficient to make it more efficient, to get the response better. Does that make sense? So you still have to do a complete neurological exam, and then you find things that are off. So as an example, this patient, let's say, has that right-sided tremor, so you know the left basal ganglia is not healthy. Now, obviously, they have a progressive neurological disease, so you have to kind of figure all those factors out. But now you can do an exam, and instead of having the horizontal canal off, okay, they have, with this whole basal ganglia, they're completely unstable. They sway to one side, they fall to one side, right? Or they have Romberg, so you check their anterior canal, and their anterior canal stabilizes them. Do some anterior canal stimulation for a while. You have them visualize like they're doing rolls visually in their head. You go through some of those things. You have them visualize their body floating in the direction of the anterior canal, or they're falling in that way. You do some of those things, and then you see if their tremor or other neurological symptoms start to change. With Parkinson's, the tremor is not always the best thing to check. It's best to check their tightness, like straighten out their leg, and then do some therapy, and then see if their stiffness goes away, or if the stiffness improves. Okay, now take a look at this one. The right side or left side? Right side or left?
Left side.
Left side, yeah. Now your right side, you have to use your whole arm. Okay, right away, what area of the brain? Okay, so you guys are seeing a slowness on the left side, right? Hypokinesia on the left side. So that's the right basal ganglia. What's ipsilateral to it? Right cortex, contralateral vestibular system, contralateral cerebellum. Okay? It is possible to do stretching and effects on the left leg to impact that? Maybe, right? I'm sorry, I'm using my right as an example. Left hand is off, so right cortex. So you can stretch the left leg, fire the cerebellum that way. You can do vestibular canal activity. You can do rotational chair, right? You can have them do focused and concentrative activities. You can do saccades, you can do optokinetics to activate the frontal cerebellar pathways and see if that changes. Okay. Now, let's watch this one. What are you guys seeing with that? Let's go back. Oops. I get a clean. There we go. So these are vestibulocochlear reflexes, and as the person rotates, as it goes up, it's moving to the left, and as it goes down, it's moving to the right. You see these movements like that. So they're having vestibulocochlear reflexes all the way through here, and then after about 5 seconds, it flattens out. So they don't have them anymore after 5 seconds. That's fatigue. So watch. Those are the results. This is just a video playback. Eyes are moving. And then the stimulation's still there, but it completely fatigues. And you see the ptosis happening on the left eye. And you see the fatigue there. So that's a whole different finding. So you did some optic kinetics for the first couple seconds. What happened? It's pretty good, and then the guy shut down. Now, what if the person said, I am so dizzy right now, I'm going to vomit? That was repeat testing that now caused a new symptom. So they're very, very unstable. Versus they did it, and then they feel really tired, and they're okay, right? So the second scenario is they're more stable. So those are the things you want to consider as you go into therapy. Okay. Now, let's go over some other things. Patient comes in, they just tell you, chief complaint, ADHD. Can you think of a treatment protocol? First of all, what area of the brain? Frontal. Now, things that I want you to understand also is when we talked about the diagram, let me show you something. This diagram with repeat testing. Notice on the top part of this flow chart, we put, you do an exam, and then you have normal, and then you do repeat testing. But are you going to do repeat testing with every normal examination finding? No, because that's going to make your exam take way too long. So when would you start to really push things? If you do a test and it seems normal, when would you really do repeat testing or do some provocative activity? When you suspect that the area of dysfunction could be there. So if someone comes with ADHD, and you, let's say, check their saccades, and you check their fine motor activity, and they do it once and it seems okay, that might not be enough. So you keep doing it, and then you see if they totally break down. Okay? Now, the areas you'd want to really dig deeper into is based on your understanding of the neuroanatomy and their chief complaint. And one of the things that can really help you dig in certain areas more when you first have an initial exam plan that's normal, but you want to push it and provoke it, is if the person has any area that shows up on the brain region localization form. Okay? So let's say I come in and I have cerebellar symptoms of my brain region localization form. They're all like 2 and 3s out of 4. This frequent symptoms of cerebellar dysfunction. So then you do Romberg's, and I do Romberg's, and I go, okay, close your eyes. You go, yeah, good. Versus, whoa, hey. Let's make sure you do this again, and really let's make sure we do the pointed one, and make sure you don't cheat, and you're going to be very careful doing that, right? And let's have you do it with head positions now, and then you find that with head positions they're all over the place. Now they totally fall apart, and have lots of symptoms develop. So sometimes you have to target the area in your exam, even though the initial exam finding is normal, and then provoke it into repeat testing to see if things show up. And that's why it's important to know your neuroanatomy. Like with the ADHD kid, you know right away you're going to really assess those frontal lobes very, very aggressively. So you repeat testing to evaluate endurance. If you have abnormal findings after repeat testing, you know you have impaired neuron endurance. So you rehabilitate within limits to consider metabolic function. If there's no change in exam findings when you repeat testing, then it's fine, and you move on. Okay, so that's important to know. All right, now let's do another scenario. What if someone comes in with acute dizziness? That's their chief complaint. Well, that's a big list. Could they have had a stroke? Could they have had a TIA? Could it be a vestibular migraine? Could it be vestibular neuritis? Could it be Meniere's? So that's where you might have to do some diff dyes, but you know it's at least localized to the vestibular cerebellar region. And if someone had this, you know what you can pull out right now? You can pull out the vestibular localization form we handed you guys. And you can go through those symptoms and go, well, this isn't Meniere's. They don't have hearing loss. There's no pressure in the ear. You know, this may be vestibular neuritis because it's acute. They just had an upper respiratory infection. That's the history of one. Maybe that's what's going on, and that's the most likely thing. And so then they may need to get some kind of pharmaceutical to get that under control until they get out of the acute phase. Okay, so everyone's a little bit different. What if someone comes in, this is their chief complaint, repeated ankle sprains, repeated right ankle sprains. So what can cause that? Left parietal lobe issues and a somatotop distribution of their feet. So if they come in with that, what's your exam